Assalamu alaikum. Welcome everyone. I'm Dr. Abdurrahman Ammari, dental intern in Riyadh University, and I'll be the moderator for this webinar. I would like to thank Saudi Society for Restorative Dentistry for giving me this opportunity. On behalf of Saudi Society of Restorative Dentistry, we would like to welcome Dr. Mahmoud Al-Farisi and Dr. Hila Sambo. Dr. Mahmoud Al-Farisi studied at the University of Dundee, Scotland, where he received his Bachelor of Dental Surgery in 2011. He was awarded the Andrews Harmony Prize for Innovation in Research and Teaching for his various academic contributions. In 2016, he completed his specialty training in prosthodontics at the University of Southern California and completed his Master of Health Professions Education at Loma Linda University in 2017. Currently, he's a full-time prosthodontist at Asnan Tower in Kuwait and the co-founder of Nexus, a dental education group. Dr. Al-Farisi is the editor and co-editor of several privately published books and has lectured at national and international levels. Dr. Mahmoud, you are most welcome to start your implant restoration segment or screw facts and points of your presentation.
يعطيك العافية دكتور عبد الرحمن ما قصرت مساكم الله بالخير جميعا. We'll start this presentation on cement or screw retained restorations. We'll be presenting some facts and some point of view about these kind of restorations. Once you start working, the day you deliver the case isn't the day you're finished, it's actually the day that things start. That I have learned in a long time practicing. And once you do so, in reality, as a prosthodontist, we work with a lot of different types of cases. There are no two cases that are the same. We deal with implants, teeth, a mix of implants and teeth. I deal with oral surgery, orthodontic cases as well. So each case has its own ups and downs, pros and cons, and you need to think very careful when treatment planning those cases, because it's the moment that you deliver those cases, it's not the moment that you finish, but you actually need to think that you're going to keep those patients for a long lifetime. So one of the decisions that is constantly need to be made on a case-to-case basis is whether my restoration is going to be cement or screw retained. Now, during the presentation, I'll try to present the facts so you can decide on which one is better than the other, depending on the case you're working on. I'm not saying that there is one better than the other, but I am saying that each has its own advantages and disadvantages. But implant restorations also come with complications. The complications can arise with the fit of your prosthesis, screw loosening or screw fractures, porcelain chipping and fracture, framework fracture, and you also get some biological complications like peri-implant mucositis and peri-implantitis. You might get fistulas around your restorations and bone loss, of course, around implants, and more dramatically, implant loss and fracture. So you really need to think about the complications that's going to happen and how you're going to deal with them. As a full-time private practitioner, to me, time is money. So the less complications I have and the less patients that come back to me to deal with those complications, it means I can see more patients and less of a headache. So just an overview for those who are new to implants or just to keep up the level with everyone. Cement retained restorations are done by having an implant restored or an abutment screwed to that implant using a screw, and then the crown is cemented on top of that abutment. While for screw retained restorations, you can do them in two ways. Either you also have an abutment that is screwed to the implant, and then you can have another screw that holds the prosthesis on top of that abutment, or you can have the crown or the prosthesis directly connected to the implant. So with screw retained restorations, you can either have an abutment as an interface, or you can connect the crown directly to the implant itself. So there are a lot of considerations you need to think about when you're deciding between screw or cement retained restorations. Some of the factors that we're going to be covering today are going to be the aesthetics, the fit, the retention, the way of provisionalization, occlusion, and retrievability of the prosthesis. Now, deciding whether to have a cement or screw retained restorations I need to emphasize, shouldn't be an aftermath decision. Meaning, when you're doing your treatment plan, during that phase is the right place to decide if you're doing a cement or screw restorations. But sometimes, in reality, this is not what really happens. Sometimes you get patients that come with the implants already placed, and you have to deal with those kinds of patients. So, retrievability is the most advantage of having screw retained restorations. Wherever you read, you'll see that the biggest advantage of having a screw retained restoration is retrievability. Let's take this case for an example. If you have some porcelain chipping, it's very easy to deal with that complication by accessing the screw access hole and removing that restoration and dealing with it, either by veneering the chip or stripping the porcelain, saving the framework, and reapplying the porcelain again to it. However, if this case comes in, which is a cement retained FPD with porcelain fracture, you may or may not be able to remove that prosthesis from a cemented abutments. Now, a lot of people say that they use temporary cement to fit the prosthesis. I use temporary cement when I'm doing cement retained prosthesis, and I can assure you, and if you speak to a lot of clinicians, they'll confirm what I'm saying, is that you're not always able to remove that prosthesis without destroying it. Sometimes you're lucky enough that the implants are placed in an ideal position and you can access the screw through the occlusal surface, but in many times you need to destroy that restoration in order to make a new one or salvage the problem. So at that point, a screw retained restoration is very beneficial when it comes to retrievability, because you can deal with a lot of complications much, much easier with less time, and will save you a lot of money. The second factor we need to consider is retention. Okay, as I said earlier, we're cementing the crown onto an abutment beneath that. Okay, so the abutment that you're going to be using, you really need to consider many factors about that abutment. With abutments that are on implants, the same principles of fixed prosthodontics apply. You need to think about the height of the abutment, the diameter of the abutment, how much it's tapered, the surface roughness, and if you're connecting more than one abutment, you need to think about the configuration, the alignment, are you going to be cantilevering or not, and the abutment to crown ratio. So the picture I have here, you can see that the abutment is short. It's not ideal height, or we're compromising the height a little bit. So when you have cemented restorations, you need to think about the restorative space you're dealing with. You need to think about how much height you have, the diameter of your abutment. Being able to do customizable abutments means that you're in control of many, many factors that I've mentioned here, which means the more ideal you make your abutment, the harder it is to get a loosened abutment or the crown falls off, but at the same time, it becomes harder to remove it in case you need to do so. And for those reasons, I'm really not a fan of those prefabricated abutments, stock abutments that you just screw them and connect it and cement the crown on top of them, because I don't really think they have all these principles applied. Anything that is stock wouldn't be ideal for the things that we're talking about. So the retention on those is questionable to me. However, you might be faced with situations like these, where you do not have enough restorative space. And as I mentioned earlier, the height and diameter of the abutment plays a big role, because the mode of retention for the crown onto that abutment is using cement. And if you have limited restorative space, there isn't enough surface area for the abutment and the crown to have good retention. So in those cases, you might be really limited just to use a screw retained restorations, like it has been done in this case. And the limit for those cases is about 4 millimeters. 4 millimeters would be enough for you to fabricate a screw retained prosthesis, but it wouldn't be enough for you to do a cement retained prosthesis. Although the emergence profile and the shape of the crowns is not going to be ideal, but it is a mode of retention where cement would not be an option for you. The third factor is aesthetics. When you look at aesthetics, many people complain that you cannot screw or you cannot restore the screw access hole in an aesthetic way. Sometimes you see that grayish if it's a PFM. And there are ways and techniques that you could hide those that grayness that comes out from the screw access hole. It's not a really big issue when it comes to anterior restorations, because usually the screw access hole is hidden in the cingulum, but it's can be a problem when it's posterior restorations and you have picky patients. Today, with the use of zirconia restorations and you don't have that metal collar, it's much easier to achieve those kind of blend in of those composites in those posterior restorations if you spend enough time doing so. However, the really tricky point when dealing with screw retained restorations compared to cemented restorations is if you have cases that you're doing teeth and implants at the same time and you're restoring those teeth with Emax restorations or lithium disilicate. Now, lithium disilicate is a transparent material. You can have some differences, or you definitely have differences when you compare Emax restorations to a PFM. And if you look with a, just a second, if you look here, sorry. So if you look very closely to that restoration, one of the premolars is crowned using Emax, and the second premolar is a PFM screw retained. You can see that slight difference in color match. So if you're trying to match an Emax to a PFM that is screw retained, you need to have a very talented technician to have a very good color match. In these kind of situations, cement retained might achieve you a better result because you can fabricate an Emax crown that is cemented to the abutment. But the solution to that is easy. If the implant is placed in an ideal position, you can still have a hole in that Emax crown, and you do it in 2 steps. The reason behind what I'm saying is because the porcelain that is used to fire on PFM is different than the porcelain in lithium disilicate. So to get over this problem, you can do your screw retained as 2 parts, what they call screw-mentable restorations, is having an abutment, and then you have an Emax crown cemented on top of it outside of the patient's mouth, but keeping that screw access hole still accessible for the screw to deliver on the restoration. The 5th point is occlusion. And the people who are pro-cement retained would say that you have better control of occlusion when you're using cemented restorations because the occlusal surface is intact. You don't have the screw access hole. And the problem with the screw access hole is covered with composite, and composite opposing enamel or porcelain wears off with time. And that's the issue that the proponents of cemented restorations talk about. However, in reality, this isn't really a big problem because the screw access hole is as big as the screw head diameter. And if you have contacts on porcelain, you don't need to have 3 points of contact on screw retained restorations to have a stable occlusion. All you need is 1 or 2 points. That 3rd point is not going to be a problem if the composite wears off of it. You won't be having any loss of occlusion. The problem, however, becomes evident using screw retained restorations if you're using narrow diameter implants and you have limited space where the screw access hole is actually taking a large amount of the occlusal table, and then you do not have control of occlusion. In these cases, yes, you might be limited to using a cemented restoration. Provisionalization of implant restorations plays a big role if we're talking about aesthetic areas, especially the anterior areas where you need to manipulate the soft tissue around the implant. Having a screw retained provisional allows you to manipulate that soft tissue very easily because it's easier to remove and put back the provisional by adding or removing acrylic to shape that soft tissue to that desired position. Once you do so, then you can take and capture that molded soft tissue into your impression in order to fabricate your final prosthesis. And there are several ways in order to do that. Either you can pick up your temporary restoration with your impression when you're taking the final impression, and you can use an open tray technique where you can access the screw hole of the temporary restoration through the impression tray, and then you take it out, unscrew the holding screw and remove that provisional out with your impression and get it poured. This way you can have the emergence profile section that is submucosal captured into your cast. The other way is you can do a customized impression coping. Once you have manipulated the soft tissue and you're happy with it, you can take that provisional and embed it into some stone using a lab analog as well. And then you can connect an impression coping, and with that void created by the previous provisional, you can fill that with GC resin or any type of acrylic. And this way you can capture this submucosal area into your impression coping. And this way you have a customized impression coping. Then you can use that coping, place it in the patient's mouth, and take a pickup impression with that molded submucosal area. Once you pour that, you have exactly the shape in your cast using the soft tissue material. And at the end, you can fabricate a final restoration that looks the same as your provisional restoration. A third way that I haven't included slides in that is that you can do the same way. You can take that provisional restoration, put it back into the cast, and then inject soft tissue material around it. Now, the final point we're going to talk about is fit. A lot of people say that when you use a cemented restoration, you have better fit with cemented restorations because you use cement, and that cement space that is created when fabricating the framework gives away a little bit of the problem, while compared to a screw retained restorations, you have to have the fit exact so the screws can go into their place, especially if you are splinting your restorations together. But let's talk a little bit of some of the facts that are involved in the process of fabricating an implant retained restoration in order to understand where those errors come and how we can fabricate a precise passive fitting restorations. So this is just an example of the workflow of doing a PFM restoration on an implant. You have the implant, you'll attach your impression coping, you're going to take your impression, you're going to remove it, you're going to attach a lab analog or an implant replica, you're going to pour your cast, you can put a UCL abutment, you do your wax up, cut back, then you're going to cast that cut back, and then you're going to relieve the porcelain on top of it and deliver that restoration. Each step in that workflow would involve some errors because we have materials that shrink, we have materials that expand, and we have the most accurate, which are the machinable parts, are the, let's say, most accurate items in that process. And those machinable parts are your implant, your impression coping, your analog, and your abutment. But what needs to be understood is that even those parts, they do not fit 100% together, okay? When these parts are machined, the ISO standards have something called the ISO tolerance, okay? And if you can look at the SEM image at the bottom of the screen, when those two parts are placed next to each other that are supposed to fit, or they're claiming they're fitting, and they are fitting, but if you look at the very close SEM image, you can see that there's some micro gaps or some discrepancies, and these discrepancies are acceptable in ISO standards because in reality, you cannot have two parts fitting 100% to each other, even at that microscopic level. So when we have two parts fitting in each other, we can have them fitting either as a clearance fit or as an interference fit, okay? And the example I have here is of an external hex implant, but the same concept applies to internal connection implants as well. So with a clearance fit, the part with the hole is bigger than the positive part, okay? And they'll fit together because the hole is bigger than the fitting part. When it's an interference fit, the hole is smaller than the positive part, and friction holds the two pieces together. Most implant parts, they are made with the clearance fit because there are some problems with the internal fit, with the interference fit in terms of holding the positions together and transferring those positions. So clearance fit is the most used mode of fit in implant components. Now, been in 1995, and that's an old study, I'm pretty sure the implant parts have been improved by today. When you have a clearance fit, and I'm exaggerating with this image here, if you look at the inside, there are two hexes in those images. There's an inside hex and there's an outside hex. The outside hex would represent the outer border of the hole or the negative part, and the inside hex is the positive part. And I'm exaggerating the gap in between them. But what Binnen did in his studies is he connected an abutment to an implant, and then he screwed them together, and then he started rotating them to see the amount of rotation that is possible with a clearance with components, and he tried different companies. And you can see that I'm trying to animate here, those parts rotated clockwise and anti-clockwise up to 10 degrees. And I'm pretty sure that the implant components, they are much, much more improved compared to the time that he did the study. But you have to understand that movement is still possible no matter how good they make the parts. So there is some degree of inaccuracy even with our machined components. So when we're taking final impressions, you need to understand that there are factors that would affect those impression accuracy. And these factors include the type of impression coping that you're using, the impression material that you're using, if you decide to splint or not to splint your impression copings, and the implant depth. There are two types of impression copings. We have pickup impression copings and we have transfer impression copings. For those who learned them for the techniques, the pickup impression copings are the open tray technique. The transfer impression copings are the closed tray technique. So when we're talking about transfer impression copings, the closed tray technique, there could be errors transferring that impression coping from the patient's mouth back into the impression. And these inaccuracies can come in 3 dimensions, the X, Y, and Z. There could be rotations once you put it back, and implant companies have included anti-rotational features, but you need to understand that some rotation is still possible within that impression. And there also could be discrepancies in the Z-axis. When I say in the Z-axis, meaning you can either over push that impression coping into the impression, or you can under push it into the impression. And of course, movement could also happen. You could place it correctly, but by the time the impression is moved from your clinic all the way back to the lab, or when the lab technician is placing it onto the vibrator while he's pouring the cast, those impression copings could move and errors happen. I'm not saying that I do not use transfer impression copings. I use both kinds of impression copings. I use transfer and I use pickup. But if I ever use a transfer impression coping, I make sure that I attach the analog and place the impression coping myself into the impression and make sure it fits very well. Now, with a busy clinic, when you have a busy schedule, you need to be careful not to over push or under push it, because these errors could happen when you're not paying a lot of attention. The other factor could be the impression material itself. And the most commonly used impression materials in implant dentistry are polyvinyl siloxane and polyether. And there are many studies available in the literature. There's no significant difference in the impression material in terms of accuracy. And these has been measured at an abutment level and at an implant level. However, you need to be careful and to understand that polyether swells over time due to the absorption of water or imbibition. And this means that if you're using polyether, you have to pour your impression within an hour from taking that impression. PVS, polyvinyl siloxane, is an addition silicone, so there is no byproduct and it does not absorb or evaporate water, so it's more dimensionally stable over time and you can pour it multiple times. And lastly, the deeper the implant, the less force it's required to move an impression coping from the impression. And I don't think you need a study to confirm that. It's simple physics. If the implant is placed deep, when you take your impression, the impression coping incorporated into the impression is going to be minimal, so it'll be much, much easier to move. In those cases, as you can see, there is a GC resin in those 2 middle implants. I would recommend splinting those impression copings so they're more stable and held in place. So, splinting, should you splint or you shouldn't splint? And if you look at the literature, the literature is flooded with studies comparing splinting and non-splinting, again, both at implant level and abutment level. And what I can tell you is that you can find studies that say splinting is better, no splinting is better, or there is no difference. And also on an abutment level, some say splinting is better, some say there is no difference. But if you take a closer look on those studies, you'll find that the standard deviation in the results mentioned in those studies is bigger with non-splinting impression copings, which means, yes, when you look at the results from the outside or from an outside look, yes, there is no difference. But if you try to criticize the results and look at them in more details, because the standard deviation, the chances of error, let's say, when you're not splinting is higher or they're a little bit less accurate. It does not mean I always splint my impression copings. I do not. But if you want a more precise impression, then splinting is better. To me, the step that is more important than splinting and non-splinting is verifying that the cast you have represents the same implant positions as the implant positions in the patient's mouth. And I think that's a critical step to do. So in summary, about the things I was talking about, the factors affecting impression accuracy, when we talked about impression copings, yes, I use both. Both are good. The cases that I would prefer using transfer impression coping is when I have a patient with limited mouth opening, because you're using a closed tray technique, you don't need to access, so there's no need to have a space to put your screwdriver. So in a limited mouth opening case, I would use a transfer impression coping. In a patient who has a gag reflex, I want to get my impression out as soon as possible. So yes, I will use a transfer impression coping. And in cases where I'm dealing with teeth and implants, if I'm not sure, you're doing a full arch impression, you might not be able to capture all margins within the first shot. You're going to retake that impression. You can use a transfer impression coping so the implant positions are incorporated in all the impressions that you're taking. Impression materials does not make a difference, PVS or polyether. I tend to keep my impressions for a longer time, so I prefer using PVS for dimensional stability. And when it comes to splinting or non-splinting, the cases where I want to make sure that I'm splinting is if I have deep implants or severely angulated implants. And the point with severely angulated implants is that you need to think about that when the implants are severely angulated, there is some distortion that's going to happen when you pull out that impression, especially if you have multiple implants within the same impression. If you have, let's say, 5 implants and the two most distal are severely angulated, once you take that impression out, what's going to happen is those impression copings are going to move out of the way, and then they're going to bounce back into position. And that could cause distortion of the impression material and the position of your impression copings. But when you have them splinted together, then you will have them held in place. Even if the impression material distorts a little, the chances that the GC resin is holding it in relation to the other implants is higher. So after you take your impression, the last thing you want is you deliver your frame, you put in your framework or your final prosthesis, and you find that there is a misfit in one of the implants. So the point saying is that some people say, this is why we use cemented restorations. You don't need to worry about that. The cement space is compensating for it. And again, there are a lot of studies that show that crown margins fit precisely with both cemented and screw-retained restorations. However, you need to be more precise when fabricating your screw-retained prosthesis. And the point that I said earlier about verifying your cast, if you verify the cast that you're working with, it has the same implant positions as the patient's mouth, then there is nothing you need to worry about when it comes to fit, because if you fabricate your prosthesis and it fits passively on the cast, it will fit passively on the patient's mouth. And I've done a lot of implant screw retained restorations using different materials, zirconia, hybrids, PFM, full arches, splinted restorations or in segments. And I've been having great success, and success has been mentioned in the literature a lot with screw retained restoration. So I don't think fit is a problem. However, you need to be very careful. And when I say verifying your cast, the most commonly used way of verifying your cast is using GC resin and jig, using a GC resin jig. And this could be in 2 ways. You can either connect that GC resin temporary cylinders or whatever jig you're making of on the cast, and then you can verify it in the patient's mouth. And if it does not fit, if it's not a passive fit in the patient's mouth, you can splint it, and then you can rejoin it and transfer that information back to your cast. And this way, you can verify that the implant positions are the same in the patient's mouth and in your cast. But you need to be careful when you're using GC resin and understand when fabricating this jig, you're using a lot of GC resin. And GC resin shrinks once it's set. So if you're doing it as one bulk in your cast, it will hold up in place, but there is going to be tension because it's shrinking. There is not going to be any distortion while it's still on the cast. Once you remove it, that built-in pressure is going to give in, that shrinkage is going to give in, and then you'll have a little bit of distortion of that jig. So the recommendation is you could wait 12 to 24 hours, section it on the cast, and then rejoin it. This way, the rationale is you're using less amount of GC resin, so you'll get less shrinkage, but the bulk is already processed and polymerized beforehand. You can rejoin it on the cast before the patient comes, or you can leave it sectioned and join it in the patient's mouth and verify it back on the cast later on. But GC resin is a flexible material. So even if there is a slight misfit and you're giving some resistance into it, you can flex that GC resin into place, and it could give you a false positive that it is passive, and it's not. What we used to do at our residency when I was at USC, instead of using a flexible material, we used a brittle material. So we used plaster as an index. And the advantage of plaster is if you transfer it to the patient's mouth, and if it's passive, then nothing is gonna happen. However, if there is a misfit, because of the bending and being a brittle material, the plaster is gonna crack. So it gives you a visual cue if there is a misfit, rather than depending on your tactile sensation if there is resistance of the screw. So we decided to test that. So I decided with my colleague to test this GC resin jig to see how accurate it is by trying to induce a misfit and measure that misfit to see how much of a misfit would that GC resin, would that plaster jig detect. So we brought up a cast with 4 implants, and this is the way you fabricate your plaster jig. You just make a box out of wax, and then you would pour that plaster and wait for it to set. We did that once, and then I did it as a control, and then we did it with an induced misfit. And the way we did an induced misfit is that we added some silver milers before connecting the temporary cylinder to the implant replica. And as you can see in image number 8, we created that misfit, and then we placed that plaster index again and see, and so when did it break, and measured that amount of misfit. What we found is that when we did a 5mm thick plaster jig, when the height of the jig was 5mm, it detected a misfit when it was induced with 18 mylar strips, or the equivalent to 203 microns. So we reduced the size of that plaster jig, and we did a 4mm thick plaster jig, and it was able to detect misfits of nearly 100 microns, so nearly the half. And 100 microns is a good number to detect. So once we were done, my colleague, Dr. Dalal Hajri, we carried on the second part of that study, is that we wanted to compare the GC resin jig to the plaster jig that we've done, and that we decided to use the 4mm as the dimensions of our plaster jig. And we wanted to see how do clinicians perceive a passive fit compared to a non-passive fit using both kinds of jigs. So one had no misfit. The second group had 10 milers, which is the misfit detected by a 4mm plaster jig, and one had 18 milers, which is the misfit detected by the 5mm plaster jig. And what we found out that for the control group, when there was no misfit, all the clinicians said with using both jigs that they are passive jigs. So that was easy because they were passive. When the misfit was 203 micrometers, 18 milers, all of the clinicians using both jigs found out that this is not passive because A, the plaster jig broke for the plaster jig, and B, for the GC resin, they were able to feel that resistance using the GC resin. However, when it was for the 100 micrometers misfit, using the plaster jig, 100% of the clinicians said it did not have a passive fit because the plaster broke. However, using the GC resin, they were only depending on their tactile sensation. Nearly half of them thought it was a passive fit when it had nearly 100 micrometers of misfit. And the problem is, again, as we mentioned earlier, GC resin is flexible, and that flexibility could give you a false sense of passivity. So we talked about the considerations of deciding between a cement or screw retained restorations. We covered all 6. And we need to mention then that the clinical performance of them, there is no difference in the clinical performance comparing a screw retained to a cement retained restoration. However, there are many studies and many systematic reviews that have been done very good. And they say there's no difference in implant or prosthesis failure. However, the complications or the types of complications differ between cemented and screw-retained restorations. So we'll talk about the complications that occur with both kinds of restorations. And I can't cover all the literature, but I picked up one of the best systematic reviews available, and it's done by Irina Seller and Christoph Hammerly's group. This systematic review included 59 articles. 9 of those were RCTs, 38 prospective studies, and 12 retrospective studies. And they split their systematic reviews into 3 categories, looking at single crown restorations, FPDs, and full arch restorations. And looking closer into the articles for single crowns, they looked at 35 studies, which included 1,692 crowns. But if you look at the comparison, from those 1,692 crowns, 1,400 were cement retained and only 284 were screw retained. When looking at FPDs, they looked at 740 FPDs, but around 600 of those were screw retained. And looking at full arch studies, 681 full arches, but 631 of those were screw retained. So in my opinion, the comparison isn't a fair comparison, and they mentioned that in their study, which is a good thing. A good systematic review would mention on the limitations, and here they mentioned that it is a limitation of this review, number one, that no RCTs comparing cemented and screw retained reconstructions matching the inclusion criteria were available for analysis. So the results and conclusions of this review are hence based on more or less heterogeneous prospective and retrospective studies. So they're mentioning that in this systematic review, the results they're analyzing are heterogeneous and they're mainly based on prospective and retrospective studies. So what does that mean? They say this gives a risk of misinterpretations as other variables than the fixation method, which is screw or cement retained. For example, the implant system, the implant surface, the study conditions may be more important for the outcome and may explain the differences between the compared groups. So there are differences that are available, but they're saying that there could be different variables that are the reason for those differences in here. So thus, the results should be interpreted with caution and should be tested by future RCTs. That's why I didn't include any numbers, because the numbers are going to be pointless. I'm just mentioning just an overview of what they're mentioning in the systematic review. When it comes to implant failures, there was no difference between cemented or screw retained restorations when it came to single crowns, but there was slight difference with FPDs and full arch restorations, with screw retained restorations having less implant failures. But again, they mention that the difference is statistically insignificant. Prosthesis failure, again, there is no difference. When it comes to abutment loosening, they're saying in all types of prosthesis, cement retained restorations have less abutment loosening or screw loosening. And this is one of the points that the people who are pro-cement take against cemented restorations by screw retained restoration by saying, oh, you would get less screw loosening when it comes to cemented restorations because the weakest link in the system is the cement, and you'll get the cement loosened before the screw, so it's a less of a complication. But I'll come back to that point in a minute. Screw fracture, again, in FPDs and full arches, they're saying cemented restoration had less screw fractures. With porcelain chipping, the same thing. However, they're saying soft tissue complications, screw retained restoration had more soft tissue complications, but when it came to bone loss, cemented restorations had more bone loss of more than 2 millimeters. And I think my arrow of the bigger and smaller is the opposite for the last two. So anyways, regardless of the type of complication or the incidence of that complication, if a complication happens to you, you are going to have to deal with it when I'm talking about the cases you're dealing with, right? So we could have screw fractures, we could have porcelain chipping, we can have framework fractures, and these are mechanical complications. We can split them into mechanical complications. And then you can have soft tissue complications or biological complications like soft tissue inflammation, peri-implant mucositis. You can have fistulas, you can have peri-implantitis and bone loss, and so on and so forth. With all these types of complications, retrievability of that prosthesis makes your life so much easier. And let me show you this. This is a case that came to my clinic. He has full arch prosthesis on both arches. He has chipping on his porcelain. I did not do that restoration, but he came to me with a porcelain chip. He had 6 or 8 implants, I can't remember. And the prosthesis is cement retained. And one of the abutments had screw loosening. There was no point, or sorry, I had no chance in being able to remove that prosthesis. I didn't have any chance, right? Because if you're trying to remove that prosthesis and you have an abutments that are moving with it, you cannot separate the cement from the abutment. So I wasn't able, and my only option was to destroy that full arch restoration and to make a new one. Because if you can see, you take a closer look, you can see at the connection that the implant, you can imagine where the trajectory of those implants are coming, and they're coming from the facial, and putting holes and trying to unscrew all of that is still gonna make the restoration ugly, and a new one is advocated. And having a restoration that was that tall, about 15 millimeters, trying to section that, removing it, provisionalizing the patient, and taking an impression, it took a long time. But imagine if that restoration was screw retained. It would have taken me 5 minutes to access the screw axes and remove that prosthesis, and it would be so much easier to provisionalize them as well. And save the framework if I was gonna be able to save the framework. So in order to understand the difference between cemented and screw retained restorations, I feel it's very important to speak a little bit about biomechanics. And biomechanics is a huge topic. And today, earlier today, I was giving a lecture on implant biomechanics. It's a full lecture, but I just took a little bit of some of the slides to explain a concept for you to understand. If you understand biomechanics, or at least the screw biomechanics, you can decrease the chances of having screw loosening and dealing with screw fractures. So if you imagine having an implant and a crown, and there is a screw that is attaching that crown to the implant. The same concept is like having 2 pieces held by a nut and a bolt, okay? So part A, which is the crown, you could consider that to be the top piece. Part B, which is the implant, could be the bottom piece and the nut, and the screw that is holding the crown to the implant could be the bolt, okay? So a crown and an implant with a screw is the same as a nut and a bolt holding 2 pieces together. The bottom part and the nut being 1 piece is the implant, the top part the crown, and the bolt holding them together. So this is a small video that you can see to try and imagine or understand how the things are going. So if you have 2 pieces together that you're trying to hold onto each other, and you put a bolt through them and hold it with a nut. So I'll say it again. The top piece is considered your crown. The bottom piece and the nut is your implant, and the screw or the bolt is the screw, okay? So if you take a closer look, and now we're gonna zoom in into that bottom piece and the nut. So this is the implant. The threads of the screw and the threads of the implant, once you start tightening your screw, what's gonna happen is the screw is gonna move downwards, right? It moves in a downwards position. So the teeth of the screw and the teeth of the implant are gonna hit each other. And then once you start torquing that screw, that implant is gonna elongate, right? And there's gonna be a flow of force from the screw into the implant, clamping the crown to the implant. Because once you torque, the screw elongates and snaps back into its original position, clamping the crown to the implant, and the force inside is what they term preload, okay? So the further you tighten your torque, the further the screw elongates, right? And it will elastically deform and want to go back to its original position, but it can't go back to its original position because there are 2 pieces in between. The tension force that is held within that screw is what we call the preload. And this is what holds the crown to the implant, okay? So let me explain this in one more time very simply. Once you start torquing your screw, the screw elongates elastically. It tries to go back to its original position, and it causes compression holding the 2 pieces together, which is your crown and your implant, and that is what is termed preload. Okay. So remember when we said that when we have machined parts, there is some kind of tolerance and they do not fit 100% with each other? there is a concept called the settling effect, right? And this was presented very well by Cantwell in a study he did. He took an implant and he used an abutment, he placed it on that implant, and he screwed it and torqued it. Before he did so, he took an SEM image of the undersurface of the abutment, right? And as you can see here, there is some micro roughness and some irregularities, because again, it's a machined part, it cannot be 100% smooth, okay? What he did is he torqued that screw, and then he waited. He did nothing. No force, no cyclic loading, nothing was applied. All he did was connect the abutment to the implant, torque it, and wait. And after he waited, he removed that abutment, and he took another SEM image, looked at it under the microscope. What he found out is that this surface, which was rough, now became smooth. The roughness has burnished between the two parts. And of course, he measured his preload when he applied it to the abutment, and then he measured the preload while he was removing it. What he found is that the preload, there was a loss in preload in 15 hours, nearly 25%. So that's a quarter of the preload has been lost in 15 hours without any force applied. So just by torquing your screw, torquing your crown into place or your abutment into place, doing nothing, after 15 hours, you lose about a quarter of that preload. And 40% of that loss occurred within the first 10 minutes. What does that mean? Your preload is going to be lost. From the moment you finish your torque, you're going to start losing that preload. And the more the patient uses that crown, right, when he chews and there's occlusion and there is force on top of that crown, you can imagine that there's more settling effect because more parts are going to be burnishing against each other. So you lose that preload, and the chances of your screw loosening is going to be high. So what is the recommendation? The recommendation is that you should retorque after 10 minutes. And I think 10 minutes is a random number. There is no reason why they Siamos chose 10 minutes. I just think 10 minutes is a practical number for real life situations. But there is going to be continued loss of preload during the next days, especially when the patients start chewing. My recommendation would be, and this is the way I've been taught in school, is that once we delivered our final prosthesis, we waited 2 weeks, and then we retorqued the screws again before closing screw access holes with composite restorations. Now, in reality, in private practice, when you have a busy private practice, this can be or can be not practical depending on the schedule you're having. But in my case, the full mouth rehabilitations, I always give a night guard. And it takes about a week for the night guard to be processed and made in the lab. So once I deliver the final restoration, we take an impression for the night guard to be fabricated. And this is when I retorque after a week, just to make sure everything is fine on the day of delivering the night guard. So if you do so, you can reduce the chances of having screw loosening and having the complications of screw loosening, fracture, and so on and so forth. So this was the mechanical complications part, but there's also some biological complications. And in order to understand the biological complications, you need to understand the difference between a peri-implant mucosa and the gingiva around teeth. Around teeth, we have a PDL attachment on the root, and with implants, there is a bone to implant contact directly. When you look at the fiber attachment at the root surface, you can see there's fibers that can go in a horizontal direction, oblique direction, and transverse. But because there is no fiber attachment with implants, the orientation of the gingival fibers is more or less with the long axis of the implant. So why is that important? The orientation of those gingival fibers, when it's around teeth, because it goes in an oblique and a horizontal direction, it gives more resistance when you're probing, and gives more resistance to disease and inflammation. But when the long axis of when the fibers are in the long axis of the implant, there is less resistance with that peri-implant mucosa. And this is why you can probe very easily around implants, and you don't feel the same resistance as you feel when you're probing the sulcus around teeth. So why am I bringing that into the complications and biological complications? If you have an abutment and a cement retained crown, once you put cement and you try cementing that crown, if there is excess cement, because there is no resistance, that excess cement is going to be pushed down the sulcus, and it's going to be very hard for you to remove. we don't have a problem with teeth because we have much resistance because of the orientation of the gingival fibers. This is why we see this complication with implants, but we don't see it when we're cementing crowns on teeth because of the way of the orientation and the resistance of the gingival fibers. So there are ways to remove that excess cement and to reduce that excess cement. Now, there is a lot of studies that say that you cannot remove excess cement because it goes way down, but to minimize the chances of removing the excess or of leaving excess cement is when you're fabricating your custom abutment, make sure the margin is within 1 to 2 millimeters submucosal so you can reach it very easily. Another way some people advocate cementing on the rubber dam. I don't think that's very practical. Some people put retraction cord before they cement. Some people actually take the intaglio of the crown and bring some putty and they push the crown onto that putty. So now the putty takes the shape of the intaglio of the crown. They'll put cement onto the crown, cement it back onto that putty. So all the excess cement goes out on the putty, and then they take that crown and put it in the patient's mouth, and this minimizes the excess cement intraorally. So when there is excess cement, it has been proven that excess cement is a big factor in peri-implantitis and peri-implant bone loss, and that's why in the literature you see that when comparing screw retained to cement retained, bone loss more than 2 millimeters is much higher with cemented restorations because of the inability to remove the excess cement. And this is an example of a crown that I removed. The patient came in with a loose crown, and it was a screw loosening. The screw of the abutment was loose, and I was not able to remove the crown. I looked at the radiograph and I drilled a hole, and as you can see from the orientation of where the inner part of that abutment that the implant position was ideal for a screw retained position. I don't know why this crown was fabricated as a cemented restoration. I was able to salvage the crown because I was able to access the screw through occlusally without destroying anything. I removed the excess cement and then I turned it into a screw retained restoration and torqued it back in place with a new screw. Okay, so this is understandable when we talked about cemented restorations. Excess cement is what causes the peri-implant mucosa inflammation and peri-implantitis. But why is it mentioned in the literature that with screw retained restorations, you also get soft tissue complications? And despite having good oral hygiene, we're not saying that plaque plays a role, we're saying the restoration itself. So if the cement is the cause of the inflammation, when you have screw retained, why do you still have inflammation of the soft tissues? And this is a video that's going to show you, and again, this is exaggerated, of course, but just to deliver the concept. Once you have a bending moment, meaning once you have enough force placed on the crown, look here at the interface, this crown could open and separate a little bit from the implant. I'm going to repeat this video again. So if the occlusal forces or the separating forces are higher than your preload, you can get an unstable joint and it could move, right? And with time, this is going to cause you what? It's going to cause screw loosening. And every time the patient chews and uses that restoration, this gap opens and closes until the screw deforms and you have this gap as a permanent position. So once you have that gap, what happens is the bacteria can colonize this area and becomes infected, and then you get inflammation of the soft tissue. So if you looked at the literature closely, because there are higher incidences of screw loosening with screw retained restorations reported in the literature, then of course, hence it makes sense that soft tissue complications, not including bone loss, just soft tissue complications would be higher with screw retained restorations. So if you understand the biomechanics, you get rid of the screw loosening, you can get rid of soft tissue inflammation, making sure that, of course, the patient is brushing and keeping the restoration well maintained. And if you have any complications, it's much easier to deal with if you have a screw retained restoration. So in reality, the deciding factor between an cement retained restoration and a screw retained restoration is implant trajectory. Implant trajectory plays a major role if your restoration is going to be screw retained or cement retained. So the decisions is if your implant is placed in an ideal position, it's very easy to do a screw retained restoration because the access hole is going to be either in the cingulum or in the occlusal parts of the posterior teeth. However, anatomy does not always allow you to place implants in an ideal position. And if you want to avoid the bone graft or for any other reasons, implants are sometimes placed in a non-ideal position where the screw axis comes through the incisal edge, as you can see here in the picture on the first premolar. So when you have that kind of situation, what can you do? Your options are, you can either go with a cemented restoration, you can do a custom abutment and you cement on top of that. Your other option is to use a prefabricated angled abutment like the one seen in the picture. So what's a prefabricated angled abutment? It's an abutment that is angled. It's as simple as this. This abutment gets screwed onto the implant, and instead of the screw axis hole is going through the long axis now, you change that screw axis into about 17, 30, 25 degrees, depending on the implant company that you're using. But you have to understand that because of this term, you're changing the position of the screw axis. This, where you can see the arrow, this is called the collar of the abutment. And this collar is necessary to have a prefabricated angle abutment, and it has a height. So if this was not planned for before, and as in this example, the implant is shallow, then it's going to result in an unaesthetic appearance because you're going to see that color supramucosal. So using a prefabricated angled abutment is also a decision that needs to be made during treatment planning and not an aftermath decision. Why was that a problem before? Because the screws that were made before needed to be unscrewed by having the screwdriver on the long axis of the screw. You couldn't screw or unscrew a screw at an angle. But today, there have been many developments where you can screw and unscrew at an angle. There are a lot of examples. Some implant companies do those solutions themselves. They call them angulated screw axis channels, 360 solutions, dynamic abutments, whatever the name is. And the concept is the same, is that you can screw at an angle, and this way you get rid of the prefabricated angled abutment. And the innovation in the design is having a screw head on the screwdriver that is more or less spherical, and this way you can access the screw head at an angle and be able to screw it as well. This solution was not available until a few years ago. So for these kind of situations, when you have that implant in a non-ideal position, you can change that angulation within 30 degrees, most of the companies, and you can get a screw retained restoration without the need to go for a cemented restoration. So in summary, I've reached the end of my lecture, and I think it's perfect timing to have Dr. Sumbul follow up. So in summary, if you have your implant in an ideal prosthetic position, you can definitely go to a screw retained restoration. If you have your implant in a non-ideal prosthetic position, then you have a couple of options. If it's within 30 degrees of malposition, like I showed earlier, then, and you also have adequate soft tissue height, not the same as the case as I showed you with the prefabricated angled abutments. If you have an adequate soft tissue height, then you can use either a prefabricated angled abutment or redirect the screw axis channel. However, if it was the same as the case earlier, where you had inadequate soft tissue height, then your only option is to use a redirected screw axis channel. You cannot use a prefabricated angled abutment. Of course, you can also use a cement retained restoration. If the malpositioning was more than 30 degrees, then more or less your only option is to use a cement retained restoration, or you can use a combination, but it gets more complicated. I don't want to get into that. And if you have inadequate restorative space, then you cannot use a cemented restoration. You have to use a screw retained, because there isn't enough height for the surface area for the cement to retain that prosthesis in place. This concludes my lecture today. Thank you all for listening. If there are any questions, please, Dr. Abdurrahman, if there are any questions you can direct, I'm ready to answer.
Thank you very much. Thank you, Dr. Mahmoud, for your outstanding and informative lecture. And now we'll take a few questions from the audience. The first question is, what is the minimal interocclusal height to place a cement retained restoration?
So the same would the same concept of fixed prosthodontics apply to your implant restorations. The same goes for your anterior restorations and your posterior restorations when it comes to height and width and diameter. So all the concept of fixed prosthodontics that apply to cement retained restorations are the ones that apply to teeth.
Okay, clear. The second question is, in case where you have to cantilever your implant to another crown, like an implant for tooth number 8 and cantilever for tooth number 7, do you prefer cement retained restoration?
So if I have an implant on tooth number 8 and cantilever number 7, no, actually, I prefer a screw retained restoration. I always prefer a screw retained restoration.
Okay. And the third question is, you said if there is a jig didn't verify in the patient mouth, you section the jig and put it back on the cast. How do you know which analog to remove and to reattach?
Okay, so let's say you have 5 or 6 implants, right? And you did your verification jig on the cast. You try to place it on the patient's mouth and it does not fit, okay? You're gonna section it, connect it in the patient's mouth, okay? And you can either verify it back on the cast. If you put it back on the cast without screwing, just placing it, you can see visually, because you remove the soft tissue material, and you can see visually which one is not fitting. The other way is after connecting it into the patient's mouth, you can take an open tray impression with it if you want. It's like having a splinted impression coping.
Okay, that's clear. On behalf of the Saudi Society of Restorative Dentistry, we would like to thank you, Dr. Ahmed, for your presentation and for being here with us today. And now we will move to the second presenter, Dr. Hilal Sumbul. Dr. Hilal, can you hear me?
Yes, I do.
Okay. Dr. Hilal Sumbul received his master and PhD in 2010 in Cardiology and Restorative Dentistry at Gothenburg University, Sweden in 2008. He completed 3 years clinical specialization in restorative dentistry at the same university. Dr. Hilal held the position of an associate professor at the Restorative Department, Faculty of Dentistry, King Abdulaziz University. Currently, Dr. Hilal is appointed as the Scientific Council Chairman of Saudi Board in Restorative Dentistry, and he is a senior member at the European Organization for Caries Research. Dr. Hilal Sumbul, you are most welcome to start the Caries Minute Visited, a biomimetic approach presentation.
Can you see, first of all, can you see the presentation slides?
Yeah, it's so clear.
Okay, very good.
Thank you
very much, Dr. Abdurrahman, for the nice introduction. And I would like to extend my gratitude also to the Saudi Society of Restorative Dentistry for this golden opportunity. Indeed, it's an honor to be part of these marvelous events so far. So thank you very much. As a matter of fact, we used to give these lectures for full 2 days as a workshop. However, because of the time limitation, I've decided to tackle this topic, which is a very difficult topic to tackle, from a different perspective. Because instead of talking about, or not talk about specific techniques or specific materials that should be used, rather than the biological concepts behind it. Because I have a very strong belief that without knowing the biology and the conceptual framework behind it, we will be or act as a robotics in the dental clinics, because we don't know if we do these steps, what would happen or what would be the response in the pulp. So if you allow me, I will try my best to challenge your minds, to open doors for thinking, rethinking, and reconsidering what we are doing in our dental practice regarding deep caries management. Before I move forward, I thought like it's a great idea to know how important is the topic nowadays, management of deep caries. If you dig in the literatures, searching for um, literature regarding deep caries management, you will find, according to the chart you see on the screen, that the publication started to increase since 1975 and so on till today. So it reached over or almost 800 publications in 2019. While before that year, the publications were fewer, and it's not much publications been there before 1975. So one could ask why we have that. So the answer is very simple. Everyone knows J.V. Black. He's the one who invented or the one who has the ideology of extension for prevention, where his theories says like we have to involve all plaque retentive areas in order to prevent dental caries in the futures. So the focuses at that time were about how to do a perfect cavity. What are the principles of cavity resistant foam, retention foam, and all that stuff? How we could have a great cavity to have a good fillings later on. And what kind of fillings also, the mechanical properties and all that stuff. So the literature at that time were focusing on those kind of things, ignoring the biological concept. So after that year, the shift that happened from drill and fill to treating caries as a disease has started. So the focus of the researchers started to be directed toward the deep caries management and to be more conservative. Here we come. This is actually a very important thing that I usually take like 10 to 15 slides to explain it. So I've tried my best to make it short and concise. We have to understand the differences between disease, infection, and inflammation in general and with regard to dental caries. So when it comes to the disease, if you look at the word disease, it has two colors, the red and the green. This is, that means lack of ease, difficulty facing. When we go for the definition, it is a disorder of structure or function of human and so on that produce a specific sign and symptoms. So if we don't have a sign or symptoms, we don't have a disease. So what are the signs and symptoms of dental caries? Simply, it is what we usually see in the white spot lesions, established cavitated lesions, pain, or broken teeth. So just to make it simple, if we have a patient that has a high number of mutants in their saliva, but they don't have any sign or symptoms of the dental caries, can we say that this patient has a dental caries disease? No, we cannot. So we have to have the sign and symptoms to say that this patient has a dental caries disease. So how about infection? Is it an infection? So let's go for the definition. The definition says it is invasion of the pathologic or the pathogenic microorganisms inside the tissue causing the destructions either by the pathogen itself or by the toxins or the byproduct of toxins of the bacteria or the pathogens. So we cannot say that this patient infected with dental caries on the tooth level unless we see the bacteria inside the enamel prisms and inside the dentinal tubules. So at that time, we could say that this tooth is infected with dental caries and the distractions should be evident to say so. So how about inflammation? Inflammation is something different. It is actually the biological response of our body to that pathogens or irritants in order to, it's actually a protective response in order to localize the infection and the irritants and to get rid of that eventually. So the function of inflammation is to eliminate the initial cause of injury and to initiate tissue repair. Oh, so inflammation is very important for repair and healing. Is that correct? I think I thought it would be really good to see the following video about wound healing to understand the answer of this question.
But sometimes a wound penetrates into the dermis, which contains blood vessels and the various glands and nerve endings that enable the skin's many functions. And when that happens, it triggers the 4 overlapping stages of the regenerative process. The first stage, hemostasis, is the skin's response to 2 immediate threats: that you're now losing blood and that the physical barrier of the epidermis has been compromised. As the blood vessels tighten to minimize the bleeding in a process known as vasoconstriction, both threats are averted by forming a blood clot. A special protein known as fibrin forms crosslinks on the top of the skin, preventing blood from flowing out and bacteria or pathogens from getting in. After about 3 hours of this, the skin begins to turn red, signaling the next stage, inflammation. With bleeding under control and the barrier secured, the body sends special cells to fight any pathogens that may have gotten through. Among the most important of these are white blood cells, known as macrophages, which devour bacteria and damaged tissue through a process known as phagocytosis, in addition to producing growth factors to spur healing. And because these tiny soldiers need to travel through the blood to get to the wound site, the previously constricted blood vessels now expand in a process called vasodilation. About 2 to 3 days after the wound, the proliferative stage occurs, when fibroblast cells begin to enter the wound. In the process of collagen deposition, they produce a fibrous protein called collagen in the wound site, forming connective skin tissue to replace the fibrin from before. As epidermal cells divide to reform the outer layer of skin, the dermis contracts to close the wound. Finally, in the 4th stage of remodeling, the wound matures as the newly deposited collagen is rearranged and converted into specific types. Through this process, which can take over a year,
So the inflammation, what I intended to say here, that we have to have inflammation to have a healing. And there's thousands and hundreds of publications says, like, especially for those patients who has diseases, some diseases that affect the inflammatory response, or even taking non-steroidal anti-inflammatory drugs, that would probably retard healing. So inflammation is considered very important for healing. How about pulp? Inflammation of the pulp. The pulp has a certain specific criteria that I'm going to talk about it later on shortly. So that would bring us to another thing that I would really like to ask yourself. The role of antibiotics. What is the role of antibiotics? Does it has a direct relation with the healing of any part of our body, or what actually it does? The antibiotic, what it does actually is reducing the pathogens, reducing the load of the pathogens and the irritant that we have that infected the tissue and invaded the tissue. So giving a chance for the body and the immunity system to take over and start the inflammatory things that would lead eventually to healing. So antibiotic is not the actual treatment. It is actually an adjunct tool to help our body for healing. I would say, ladies and gentlemen, healing process till now, still there is mysterious things about it in all part of our body, subhanAllah. When I think about teeth, I always think about coral, because coral is a hard tissue, hard hard creatures like our teeth, but it is alive. So our teeth, our tooth is alive. It is a vital tissue. It has a healing capacity. It has an inflammatory response. We have to respect that. And we will come to that actually in the coming slides. So as you can see in this slide, we have many questions, and I have divided these questions into 3 categories: the red section, the yellow section, the green section. The red section is all about the background, the biology background, the general aim. Is the dental pulp necessary? So if we have answered these questions, then we can come to the next section, which is the concept that we should have in mind while treating dental caries or management of dental caries. By knowing the concept, it is much easier then to move to our clinic and hold the handpiece, give the anesthesia, and start to apply that concept. And I will talk about that step by step in the end of the presentation. It's really nice to know to talk about a little bit about caries progression and the beauty of the tooth structures, because subhanallah, Allah has created us in a perfect thing. It doesn't change over the time. I would say, I always give an example, like if we have a Mac Pro laptop, it could be perfect this time, but after 2 years it will be outdated. The human body, it's amazing. SubhanAllah, it's perfect everywhere and whenever. So if we discuss the caries progression, the caries started at the enamel, which is the most strong and dense tooth structures that give that take very long time, or I shouldn't say very long, it depends on the rest, that it takes time longer than the dentin progression. So once the caries reach the dentino-enamel junction, what happens? It starts to extend laterally through the dentino-enamel junction. If you can see that, let me check if I can. Yes, it will extend laterally here first, and then start to invade the dentinal tubules. And if you can see the structure of the dentinal tube orientations, it acts like a physical localization of the infection, because as you go deeper, the dentinal tubules try to decrease the surface area reaching the pulp, subhanallah. And this is a very important thing that we should keep in mind when do the cavity preparations, because there is no need to remove the whole things here when we do the cavity preparation. Let us now go to the next question. Is dental pulp necessary in full form tooth? Apparently, yes, but why? So this is a beautiful, articles showing the function and the response to injury of the pulp. I summarize it, I would say, in 4 points. First, pulpless tooth is pulp tooth is less resistant to bacterial invasion. Why? Hundreds of things is going on there. I will just emphasize one important thing, that presence of the fluid of the pulp inside the dental tubules that contains antimicrobial agents and antibody attacking the virulence of the bacteria before it reaches the dental pulp. The second thing, presence of odontoblasts will retain the ability to form dentin throughout life. And probably you can see that when we get older or by aging, our pulp get recessed, getting smaller in size. And that's because of continuous deposition of certain type of dentin called secondary dentin. So we have many different types of secretions by the odontoblasts, secondary dentin, sclerotic, reactionary, reparative. I don't have time to discuss every one, but I will focus only on the last two, which is reactionary dentin and reparative dentin, because it's more directly related to dental caries. So the third one, presence of cellular components, as we said, the immune defense, the inflammatory response, presence of the pulp is very important for healing and for precipitations of the dentin bridge. The last thing is the pulp is a sensory organ. So if the patient doesn't feel pain, what actually happened? Caries start to progress and progress to reach to a certain or catastrophic distractions, and the patient doesn't feel. So this is a protective action of the pulp, pain. So once we have pain, patients start to seek treatment to resolve that pain. And probably one argue me about this and said, okay, Hilal, we have, if we have non-vital tooth, still the tooth is functioning in the oral cavity. So what is the difference? I would answer his question with another question. Which one is more susceptible to dental caries, vital or non-vital tooth? It's been proven that the non-vital tooth is more susceptible to dental caries rather than the vital tooth, due to many reasons, actually. It's not the time or the objective of this presentation to go through it. So this is very important slides, because now when it comes to the pulp, the special thing of the pulp that differs from any other part of the body is that the microcirculation of the pulp is located in a very limited space, in a very limited confined space. So when the inflammation, that was, as I said, very important for healing, when the inflammation degree start or to exceed certain limits or stays there for a long time due to bacterial leakage, the healing of the pulp absolutely would be compromised because of the limited space of the anatomy and the microcirculation inside the pulp chamber and the pulp canals, the root canals. The second point, the pulp vitality test. So till now, we don't have a test that strongly correlated with the degree of inflammation in the pulp. So the pulp vitality test helped us actually, well, it just increased the probability that this tooth probably is vital or non-vital, reversible or non-reversible, but it has no correlation with the inflammatory response inside the pulp. So we have to keep these two things in mind when treating a dental pulp. That after we finishing from the importance of the pulp as a whole, now let us go inside the pulp and see what are the responses that happens inside the pulp when we have an external insult come to the two structures. Even small enamel lesions or a small cavity that we used to do in enamel, it is directly reflected in the pulp, and the pulp start immediately to respond to that insult. And you can see it in many papers actually proved so. If you remember the reactionary dentin and reparative dentin that I have talked about earlier, we have to differentiate between these two things in order to know the purpose when we start do caries excavation. So reactionary dentin is actually due to mild insult that lead to slowly progressing inflammations that eventually lead to deposition or precipitation of dentin bridge from the primary odontoblast cells that is lining the dental pulp. However, the other type, which is the reparative dentin, it is different, where we have severe insult because of a deep cavity or a pulp exposure or a potent bacteria that causing rapidly progressing inflammation, uncontrolled inflammation, that lead to destruction of the primary odontoblast, okay, from where we have the reparative dentin then deposited or precipitated. It comes from non-differentiated mesenchymal cells that been differentiated to odontoblastoid cells and start to deposition the reparative dentin. So as you can see here, the process here is very complicated, and it's really depending on the health of the pulp. So the purpose is try to avoid, try to be in the side of reactionary and try to avoid the reparative dentin mechanism or response of the pulp. And this is very recent papers regarding this two different responses of the pulp due to insults. This is another beautiful also article regarding pulper reaction to restorative procedures and materials, because I think it's very important. It's not only the insult of the bacteria and the caries, it's also our insult. We as a dentist, when we start excavate the cavity, we are, if we don't be so cautious, we are increasing the chance to have destruction of the odontoblast and to bringing the responses from reactionary to reparative dentin. So it's also a very beautiful papers if you have a chance to read it. I will just focus on the table here, because here they correlated many steps in our cavity preparations that have been correlated to the pulp injury. And they found actually that the most influential variables in terms of causing pulp injury is the remaining dentin thickness between the base of the caries lesions and the pulp tissue. So as we have thinner, the more we have thinner remaining dentin, the more is the harm, the more is the inflammation, the less is the healing capacity or capability of the pulp. So all aspects of restorative treatment require careful attention to minimize injury and optimize the dental regeneration. So kindly be gentle, slow, intermittent, and use copious water while you are preparing and excavating dental caries. So as a conclusion, the pulp recovery is inversely correlated with the cavity depth. And if you look at the odontoblast survival, as we go deeper, the odontoblast start to be injured and start to be toward the more reparative dentin than reactionary dentin, and the healing will be more compromised. So removing unnecessary discolored dentin, this is very important, would affect the pulp recovery. And most importantly, finally, is try to avoid pulp exposure, because the minute we be inside the pulp means we distracted the odontoblast that is responsible for the reactionary dentin deposition. So that would lead us to one statement. In this context, the complete carious tissue removal is not the ideal thing to do if we want to improve pulp healing, provided that the teeth pass the vitality test that we do at the beginning of the session. So these papers, hundreds of papers actually talking about this, like the more we decrease the risk for pulp exposure, the more is the success of the incomplete or indirect pulp capping. Okay, so now we know we have discussed the pulpal response and how our cavity should be how we should deal with the cavities and the caries excavation. And let us now move to the third concept, which is sealability. Sealability, in addition to of what we did earlier, it is very important in order to stop the bacterial invasion. So it has actually three mechanisms. First, and the second is protection from further biofilm deposition and acid challenge. So whatever bacteria left inside, for the caries tissue inside, it will not progress because the biofilm is not there and the acid challenge is not there because of the sealing. The third and most important thing is the inhibition of the dietary carbohydrate supply of the cardiogenic bacteria. So if we have bacteria under the restoration, the diet of that bacteria cannot be reached because of the sealing of the dental filling. So what would happen for those bacteria? It's actually stayed sometimes dormant, and most of them being killed because now the pulp will take over and they will take care of them. They will start killing them by the antibodies and immunoglobulins process. This is another paper emphasizing the importance of sealing. Sealed composite restoration placed over frank cavitated lesions arrested the clinical progress of these lesions for 10 years. Wow. This is another one, incomplete removal of caries dentin and subsequent sealing would lead to suggesting that complete dental caries lesion removal is not essential to control the caries. So now we came to the general aim of the management, which is reducing the insult of the pathogens as much as we can during caries management, preserving tooth structure, sound tooth structures, and sealing by placing fine restorations. By doing so, we are letting the body and the immunity response to take over and proceed with the healing and repair. It is actually, I would say it is exactly the same role of antibiotics. If you remember, we are helping the body to take over and to do the healing by reducing the pathogens, preserving sound tooth structure for a better sealing filling. Back to our sections, the traffic light sections. Now we came to the questions about the concept. So what we are doing actually, are we removing or controlling the disease? It's a very important. From the previous discussions, we can say that controlling the activity of the caries lesion rather than removing the sign and symptoms is the issue. So I think I should read it because it's really worth reading. It's from Deep Caries Management Textbook. All conservative and microinvasive strategy aim to prevent development of caries by controlling the caries disease, but also can be used to control the activity of the existing lesions and arrest them in situ. And this is actually what we will do, and I will show you how we apply this on the clinic. So we came to the last section, which is the green part concerning the application of that concept in our clinic. Many times I ask my students when they reach to yellow dentin after caries excavation, ask them these questions: are we sure that bacteria doesn't exist there? So most of them they couldn't answer the questions, but most of them they answered the questions that no, we are not sure that the bacteria. Why? Because our eyes is not being created to see bacteria. So complete removal of caries doesn't mean complete removal of bacteria, which is the most important things regarding invasion, if you remember the infection. So the aim is to reduce number of bacteria without pulp exposure. How we can do so? Before going to the clinical application, everyone knows about infected and affected versus affected, how that we should remove infected and keep the affected. Now, before I'm giving you my statement, we should differentiate between both of them. regarding 4 points: the carious tissue, bacteria, demineralization, and collagen fibers. So as we go deeper, we will move from infected to affected, but there is no clear cut between both areas. So if you go deeper, we have actually both are carious tissue, infected and affected. When we say carious tissue, both of them are carious tissue. But when we talk about bacteria, we have more bacterial load in the infected than the affected. So as we go deeper, the bacteria start to decrease. About demineralization and collagen fibers, demineralization in the infected area, we have a complete demineralization and complete denaturalization of the collagen fibers. As we go deeper in the affected area, we have partially demineralized dentin plus collagen fibers that retain their natural composition and structures. And these two actually act as a foundation for the pulp to precipitate and deposit the reactionary or reparative tendon in the future. So the aim here is try to remove as much as we can of the bacteria and completely demineralize tissue and collagen fibers and retain the last part, which contains as much as we can of less bacteria and more mineralized tissue and more natural collagen fibers. But how can we do so? I think infected versus affected is a misleading term, because clinically our eyes cannot see the bacterial invasion, demineralization, or collagen fibers. And these are the key factors of the success of the deep caries management. So inevitably, we used to link discoloration to bacterial invasion, which is completely wrong. And this has been proven for hundreds of papers. The first one, and the guy who is really made the change about the shift, Fusiyama, he proven that there is no direct relation between depth of the bacterial invasion and the depth of the softening and discoloration. This is actually a classical paper, shows the, or try to correlate between the histological terms and the consistency. So they found that we have 4 categories of consistency: soft, dentin, leathery, firm, and hard. When you look at the histological terms, we found the necrotic zone, contaminated zone, which has abundance of bacteria and soft carious tissue. And as we go, the hardness of the dentin increase and the bacteria decrease. But clinically, we cannot differentiate. So the purpose here is to try to decrease as much as we can of the soft dentin, soft carious tissue, and the bacteria, the bacterial invasion. Okay, in this paper, beautifully, they defined the 4 types of consistency, starting from soft dentin. I think everybody listening now and all dentists knows how can differentiate between soft and hard dentin. It's very easy, and they have defined it as it will deform when a hard instrument you pressed on it with a little force. So you can remove it even without anesthesia with a hand excavator. So it's very, this is very easy, and we can do it. And also it's very easy to differentiate the hard dentin. And everybody knows about scratchy sound that heard when the probe or taken across the dentin. So it's very hard, and it's resistant to hand excavation and need more forces to remove it. So the problem is the 2 categories in the middle, which are the leathery dentin and firm dentin. To be honest, it doesn't matter. If you have leather dentin or firm dentin very close to the pulp, leave it. It's not very important to differentiate between leathery and firm, as long as we have a deep area opposite to the pulp. Once we removed it, we will have a risk of exposure. So when and where we should stop excavation. First of all, when we start excavation of caries, I always say to my students, start from the non-dangerous walls, the periphery, those walls and the periphery that are not opposite to the pulp. So start to remove caries with a high speed handpiece till you reach sound dentin enamel, periphery, and hard dentin. And then focus on the carious tissue that is located opposite to the pulp. That actually gives you a very good contrast. When you remove all the periphery, your eyes can now differentiate the dangerous area where the pulp exposure is or has a high probability. So start to remove the soft dentin at the deepest part with the hand instrument or the low speed handpiece. And it doesn't matter, you should reach a hard dentin or you should reach a very clear without no discoloration. The minute you start to expose the pulp means the pulp healing start to be compromised because of the destruction of the primary odontoblast cells. So I usually emphasize this when I give these lectures, that we shouldn't follow the discoloration. We should start with the consistency of the carious tissue, and then the smooth and shiny. Lastly, we should depend on discoloration, because discoloration has nothing to do with the bacterial invasion or the softening. So when we do the cavity, start to remove the periphery, as I said, till we reach the deepest part. And if you remember, the more thickness of the remaining dentin preserved here, the more success or less injury to the pulp and to the odontoblast that precipitated the reactionary dentin. So it doesn't matter if you have leathery dentin or firm dentin, or even sometimes soft dentin at this area when we have a very young age patient. The thing that I want to emphasize, if we remember the slide of caries progression, we have to maintain, if we can, as much as we can, we have to maintain a periphery enamel. We have to maintain enamel at the periphery of the cavity, because enamel is very important for bonding. So if we have a very strong area here, we can keep it, and we can test that with a hand excavator, try to break it. If it doesn't break, so we just keep it, because it's very important for sealing and sealability, as we have discussed earlier. Here, just show you some papers, randomized clinical trials with high evidence regarding complete versus partial removal of caries. And there's a substantial evidence that removing all infected dentin from the lesion approaching the bulb is not required. And please notice here the vocabulary here. It says partial removal, and this paper is was published on 2008. If we move on the next one, it says incomplete dentin caries removal. So we have different vocabularies for the same, different terms for the same procedures, actually. The last one, which is a very recent one, I recommend everyone read this paper. It's 2020. It used the selective, and this is actually the right term that we should use. We shouldn't use incomplete removal or partial removal. We should use selective caries removal procedures. And this is also proven that there is a high success rate for partial and stepwise versus complete removal of carious tissue. So the principles, quickly, it's preservation of dental tissue, maintenance of pulp health by avoiding pulp exposure, and providing a peripheral seal. Okay, now we have reached to the steps that where we should start place our fillings. I always ask my student to differentiate between efficient versus strong bonding, because the minute you place your restorations, it might have a very strong bonding. But when these restorations functioning in the oral cavity, exposed to higher thermal and low, increase the temperature and lower the temperature and the mastications, the efficiency of the bonding start to decrease with time. So the purpose here is to establish efficient, strong bonding rather than just strong bonding at the beginning that will deteriorate so quickly in the future. So I used to give this also an hour and a half. So I will just focus on something very important regarding bonding. We have to do selective enamel etching, because enamel needs more time for etching in order to provide efficient bonding. We can use either self-etch or single bond, it doesn't matter, but here I just want to emphasize the selective enamel etching that provide efficient and more strong bonding. Another thing that is we always have dilemma, which is wet, which is moist, which is dry. I always say we have to be in this area blood dry. Like after we wash the acid etching, we use clean brush to get rid of the excess water. That's what we call blood dry. Another thing that's very important is we have to vigorously rub the dentin surface with the brush. When we apply the dentin adhesive, it being proven it would increase the efficiency of the bonding. So rubbing means like when you wash or clean the blades. I actually have experience now in quarantine how to wash plates. So it means like we have to rub them very vigorously to be sure that the dentin adhesive reach everywhere in all line angles. This is actually the most important things is the effects of the chlorhexidines on bonding. I always use chlorhexidine 2% in deep caries or any cavity when I do before I place dental restorations, because actually chlorhexidine I would consider it silah dhu haddain. It has inhibition action of enzymes normally secreted by the pulp called MMP that attack the exposed collagen fibers, leading to leakage and debonding in the future. So it inhibits the action of that enzymes, plus it acts as antibacterial and decrease the load of the bacteria in the deepest part of the cavity or in the whole cavity. Hundreds of papers, even more, regarding chlorhexidine and its effect for the longevity of the restorations. So I used to apply it after etching with the micro brush, and then try to gently rub it with the micro brush, no washing afterward. This is actually steps just show you like when we start excavation, we have to start the boundaries. We have to be sure about the dentino-enamel junctions. If we have extension of lateral extension of it, we have to do it. We have to clean it. And then when it comes to the deepest part, we should start the low speed handpiece with a copious of water and try to avoid pulpal exposure, as I said. This is just some clinical pictures shows that, and very important when we place a base, we have to be away from the margins, as we all know, to provide more sealing. This is one case, just want to show you here after the contrast, the enamel that I left this case. I didn't remove it for better sealing in a deep caries. And I'm following this now case. This is actually being taken after 3 years. There is no sign or symptoms for this patient. I will just go quickly through some cases. These patients came with no pain, actually. It has no pain, the tooth looks intact. However, in the X-ray, there was a big lesion. So we started to remove the periphery, caries from the periphery as much as we can, maintaining the distal part to avoid injury of the neighboring tooth. And then now we see, we have a better contrast and we can see the deepest part. So start to use the low speed handpiece and remove the deepest part, leaving the discolored firm or leathery. I could remove this easily, but we have, as we have discussed earlier, it doesn't matter to leave discolored leathery dentin if we have a high chance to have pulp exposure. And after that, I placed bitter bond, and then I did the selective etching. And actually, I use here the universal bonding, so I don't etch the remaining cavity depth. I sometimes use a special light cure that has a tip, very special tip, goes inside the depth, the deepest part of the cavity, because of, as everyone knows about the light problems that would cause, that would affect the polymerization in that area. So after I build the missing part, I remove the matrix and start to use the light cure from the mesial, the buccal, and the lingual to have a better degree of conversion. And this is applied part of the composite. And this is how it looks like. And the patient has no pain so far. This is another case. Probably you see here the enamel area that I left in order to have a better sealing. And this is the final restoration. Another case. So before the last, we have, before giving the patient anesthesia or holding the handpiece, we have to take some time to gather as much as we can information, the chief complaint, vitality test, diagnose, try as much as we can diagnose the vitality of the pulp. So if we see like the probability of the pulp is high to take over, then start giving anesthesia and put rubber down, start to excavate, as I told you, to reach a sound periphery and try to preserve the margins, enamel margins, use a chlorhexidine, it's a gold standard nowadays, and then you will be ready for a final restoration with efficient bonding and better sealability. Lastly, and this is the final slide actually, I just want to emphasize one thing. I don't think the brain can accept, or the eye, our eye, accept that the straight umbrella can goes inside the slots, the bent slots where you can see it. However, with the science, if we know the science behind it, if we know the vector and momentum sciences, it could be possible. It could be possible, and our eyes would accept that as long as we understand the biological concept, understand the science behind it. So if I said leave caries now, I think you should accept that because you have the concept and the science behind it. Thank you very much, and I'm ready for any questions.
Thank you, Dr. Hira, for your outstanding and informative lecture. And now we will take a few questions from the audience. The first question is the reparative dentin came from a new odontoblast after bulb injury compared to regenerative?
I'm sorry, I didn't get the last. You mean the source of reparative dentin, the difference versus the reactionary dentin?
Yes, I think that's what does it mean?
Yeah. The reactionary dentin, the source of dentin bridge is the primary odontoblast present in the pulp tissue, lining of the pulp tissue. However, the reparative dentin, the source of the reparative dentin is not the primary odontoblast because it's already been damaged either by the invasion, or by our manipulation while doing the cavity preparation. So what is actually happening, it's a very complicated process. That's why if you read that papers, you will understand it very well. The source of that is the undifferentiated mesenchymal cells that were present in the pulp tissue because of certain enzymes and certain things that is going on. It's been transferred or transformed actually to odontoblastoid cells that start deposit the reparative dentin. That's why it is a very complicated process and need a really healthy tissue, health pulp tissue to do it.
Okay.
I hope I answered the question.
Sorry?
I hope I answered the question.
Yeah, you did, of course. The second question is, in case of deep soft caries, what is your clinical recommendation to deal with?
As I said in one of my slides, the main idea is to reduce the infection. So try to remove, always remember the role of antibiotic. Try to remove the pathogens, try to remove the bacteria as much as we can. So we start excavation from the periphery, non-dangerous wall first, and then start to remove caries from the deepest part where the pulp were very close. If we reach to a firm or hard or leathery dentin, it's fine. If not, still we have soft tissue. Here, sometimes I evaluate, to be honest. If the age of the patient is young, then there is a higher chance to have a good healing. So I just seal the cavity, apply chlorhexidine, put the base, and follow up of the patient. And this is very important to follow your patient. In case the patient develop sign and symptoms of a root canal, fine, that's very fine. Now the cavity is very sealed and it's much easier for endodontist to start the access cavity without any leakage for their sodium hypochlorite later on. Okay. So I sometimes, I can sometimes leave soft caries, but I always consider the age of the patients, to be honest.
Okay, that's clear. The third question is, how to determine how much we can leave soft caries that is close to the bulb?
This is a very good question. Many papers actually discussed some methods to do so, like using Keriosolve or Diagnodent. There is some papers they use Diagnodent at the depth of the cavity, or the caries that die. But actually, to be honest, till now, none of them has an evidence. So it is more or less depends on the experience of the dentist. What I usually do, as I said, I remove, the most important for me is to remove the carious tissue from the periphery. This is the most important. Even if I left soft caries opposite to the pulp, it's fine. The idea is not to do a risk of pulp exposure, because once we have pulp exposures, forget it.
Okay. The fourth question is, what do you think about the role of antibacterial composites? And is it available in the market?
Yeah, it is available. Actually, I haven't read a lot about the antibacterial composite, but I've read some articles. But if your question meant that if it's possible to use it in the deep caries management, up to my knowledge, I haven't read any papers concerning the using antibacterial composite in deep caries management. But I've read like there is a debate about the continuity of the antibacterial effect of the composites on the long term. Is it really efficient or not? It's not yet clear. And personally, I don't use anything in my patient's mouth unless I have an evidence regarding.
Okay. The fifth question is, how can we use caries detector? And is it helpful?
This is also a debatable, but I don't use it, to be honest. I use the caries detector only in one situation, to diagnose crack. Because there is still, if you remember the slides of the infected and affected area, there is no a clear cut between that. And even the dye detector or the Cariosolve cannot precisely differentiate between both of them. As I told you, the bacteria is still there in the affected dentin. And the partial demineralization of the dentin is still there in the affected. So no a single material up to date can differentiate between those two things with evidence. So I prefer to train your eyes, to train your hands, to understand the concept, rather than using such a thing in management of deep caries. Actually, I used to talk about all this in the lectures, but because of the time, it's very difficult, to be honest, to cover everything.
The last question is, does chlorhexidine application affects the strength of bonding?
Absolutely not. If you go back to the slide, I said chlorhexidine acts as a سلاح ذو حدين. Actually, it's improved the longevity and the efficiency of bonding. It's not decreasing the bonding. It's improved the efficiency. Well, how? Because it inhibits enzymes called MMP that would attack exposed collagen and would affect the bonding strength in the future. So it's actually improving the efficiency of bonding. The second thing, it will act as antibacterial to decrease the load of the infection inside the cavity, giving a higher chance for the body and the immune systems to take over and to proceed with the healing process.
Okay. On behalf of, that's it. That was the last question. And on behalf of the Saudi Society of Restorative Dentistry, we would like to thank you, Dr. Hilal, for your presentation and for being here with us today. And now the mic will be moved to Dr. Sultan Birrimal.
Thank you very much.
Thank you, Dr. Hilal, for this nice and informative presentation. MashaAllah, we have about 110 questions, so we cannot answer all these questions, but I'm sure Dr. Hilal in his social media account in the Twitter or Instagram, he can ask this question if you can go and ask him directly. So thank you, Dr. Hilal, for this presentation. We would like to announce about our next webinar. It will held, inshallah, next Sunday, May 10th. We will have a collaboration with the Saudi division of the International Association of Dental Research, the IADR Saudi division. So we will have a mini symposium talking about the current trend in restorative dentistry research. We will glad to have 3 speakers, 2 of them from King Abdulaziz University, Prof. Ahmed and Dr. Turki Pakhash. And we have 1 speaker from University of Washington School of Dentistry in Seattle, Dr. Alazera. So this mini symposium will be held, inshallah, next Monday. For the registration, the link is the code here is available. You can scan this code and you can register. And again, this symposium has 4 SME hours for the SSRD members and the IADR Saudi division members. Thank you all, and stay home. We'll see you inshallah next Sunday.